Welcome to the debate. Today, we're walking into a minefield. We are discussing the incredibly high-stakes world of pediatric risk management. And it is a field defined by this really terrifying paradox. If you look at the malpractice data, adult care physicians, surgeons, internists, they face a much higher frequency of lawsuits. They just get sued more often. But pediatricians? They face a significantly higher severity. When a suit hits a pediatrician, it hits harder than almost anything else in medicine. We're talking about indemnity payments that are consistently among the most expensive in the entire industry.
It's a fascinating and, terrifying dynamic. You have a specialty that's generally considered, low liability. Most pediatricians will go their whole career without seeing the inside of a courtroom. But because of that low frequency, there's this kind of false sense of security. And when things do go wrong, the financial and emotional costs are just absolutely astronomical.
And that brings us to the central tension we need to resolve today. In a field where a misdiagnosis in an infant can lead to, decades of lifetime damages and millions of dollars in payouts, what is the clinician's strongest defense? Is it rigid defensive documentation and adherence to standard of care protocols? Or is it the nuance of communication and relationship building?
Right. It's the difference between treating the chart and treating the family, really.
I get the sentiment, but let me be clear about where I stand on this. Given the catastrophic risks involved, specifically regarding lifelong disability, the clinician's primary shield has to be objective procedural rigor. You need bulletproof documentation. You need strict adherence to escalation protocols. When the stakes are this high, being nice doesn't keep you out of court. Precision does.
See, that sounds safe on paper, but I think it misses the human reality of why people sue. The data is overwhelmingly clear on this. Lawsuits rarely stem from just a medical error. They stem from families feeling dismissed or uninformed or blindsided. So my argument is that your primary defense isn't the chart at all. It's what the source calls safety netting and the soft skills of communication. The chart is just a receipt. The safety is in the relationship.
Well, let's talk about the math behind my position, because I think people underestimate the why behind all that rigor. We're dealing with long life expectancy equals larger lifetime damages. If a 50-year-old man suffers a malpractice injury that prevents him from working, the damages are calculated based on maybe, 15 remaining working years? But when an infant suffers a misdiagnosis, say a missed meningitis case that leads to brain damage, that injury leads to 7 or 8 decades of future medical care and lost future earnings.
It's a brutal calculus. Yeah. You're effectively paying for an entire human life that hasn't been lived yet.
Exactly. The financial weight is crushing, and because of that, the margin for error is effectively zero. Plus, you're dealing with what the material calls developmental vulnerability. An infant cannot tell you their neck is stiff. A 6-month-old can't describe that their testicle hurts. The patient, they can't advocate for themselves. So the clinician must rely on high specificity objective exams. The chart becomes the only immutable record of reality years later. If you didn't write it down, in 5 years, when that kid is in a wheelchair and the jury's looking at you, it didn't happen.
I don't dispute the vulnerability of the patient or the tragedy of the outcomes, but I think your focus on the record of reality ignores the reality of the room. A technically perfect chart does not prevent a lawsuit if the family didn't understand the why. If a mother leaves the ER thinking her child has a stomach flu and it turns out to be appendicitis, she sues because she feels betrayed, not just because you missed the diagnosis.
But feelings don't win lawsuits. Facts do. If I documented no rebound tenderness, abdomen soft, I have a defense.
Wait, hold on. You think a jury is going to care about no rebound tenderness if the mother gets on the stand and says, the doctor barely looked at him and didn't tell me what to watch for? You can't document your way out of broken trust. This is where safety netting is the actual shield. It's not just about what you found, it's about telling the family explicitly when to worry.
Okay, let's get into the weeds on safety netting, because I do think it's often done poorly. You're not just talking about saying, come back if he gets worse, right? Because that is legally useless.
Correct. Yeah. Come back if worse is just lazy medicine. The guidelines are clear that safety netting requires specific, plain language. If you're sending a kid home with abdominal pain, you don't say, return for worsening clinical status. You say, if the pain moves to the right lower belly, or if he starts vomiting green fluid, or if he won't walk, come back immediately. You're giving the parent the keys to the diagnosis. You're empowering them to act.
I agree that specific instructions are vital. But here's where your relationship argument falls apart without my rigor argument. You can say all those perfect things to the mother. You can be the most empathetic doctor in the world. But if you do not type the phrase, caregiver, verbalized understanding of return precautions, you have exposed yourself to massive liability.
You think that phrase is some kind of magic bullet?
I think the phrase is evidence. If the chart is the only record reviewed 5 years later, the fact that you had the conversation is irrelevant if you didn't document that they understood it. The verbalization is the key. You can explain right lower belly pain all day, but if the chart doesn't say mother verbalized understanding, it is your word against the grieving parents, and the jury will always side with the grieving parent.
That phrase, verbalized understanding, is important. Sure, I'll grant you that. But my worry is that clinicians treat it as a checkbox, you know? They type the macro, but they don't actually check for understanding. If you treat the chart as a shield rather than a record of care, you might win the lawsuit, but you still failed the patient. Documentation should support communication, not replace it.
Let's apply this tension to something a little more visceral. We need to talk about the sensitive exam. This is where the pediatric paradox really shows its teeth. Take the classic nightmare scenario. A 7-year-old male comes in with dysuria, painful urination, and some vague scrotal pain.
Potential testicular torsion?
Right, exactly. This is a time-critical emergency. If the spermatic cord is twisted, you have maybe 6 hours before that testicle dies. If you miss this, you are looking at permanent disfigurement, fertility issues, and a massive lawsuit. My position is that in this scenario, there is no room for soft skills causing a delay. The protocol must be rigid. You need a chaperone. You need to touch the patient. You need to document the cremasteric reflex.
And for those listening who aren't urologists, maybe explain what you're looking for there.
It's a specific reflex. You stroke the inner thigh and the muscle should pull the testicle up. If you stroke the thigh and the testicle stays down, that is a massive red flag for torsion. My argument is that you must document. Cremasteric reflex present bilaterally. If you just write genital exam normal, that is not enough. You need that specific negative finding to prove you actually checked for the killer diagnosis.
I agree on the urgency of torsion. You have to check. But let's flip the script to the other scenario that's common in the data. The 8-year-old girl with a genital abrasion from a straddle injury. Maybe she fell on the crossbar of her bike.
Sure, common injury needs to be checked for hematoma.
But think about the room. You have a terrified 8-year-old girl, she's in pain, and now a strange adult needs to examine her genital area. If you come in with your rigid protocol energy, demanding a chaperone and rushing the exam, you are going to traumatize that child. The guidelines emphasize consent and assent.
Meaning the parent consents, the child agrees.
Exactly. Assent is the agreement from the child. In age-appropriate language, you have to say, I'm just going to take a quick look to see why it hurts. I won't use any cold tools, and your mom is staying right here. If you force the protocol without getting that child's assent, you destroy trust. You might get your objective data, but you've lost the family.
I see the value in assent, obviously. We aren't monsters. But let's be real about the hard cases. What happens when the parent blocks you? This is the third rail of pediatric risk management, caregiver refusal.
This is the hardest part of the job.
It is. And the threshold is clear. Serious risk of harm plus caregiver refusing necessary care. Let's go back to the torsion case. You suspect a twisted testicle. The kid is screaming. And the mother says, I don't want you touching him there, or maybe we can't afford the ultrasound. We're leaving.
And that happens. People are terrified of bills, or they're just terrified in general.
In that moment, the clinician cannot just respect the parent's wishes. If that testicle dies, it is negligence. I argue for the necessity of what I call the nuclear note. I want to see this specific phrase in the chart. Refusal places child at risk of significant harm.
Whoa, that is a heavy, heavy sentence.
It's a necessary sentence. It is a legal and medical declaration. It triggers escalation to supervisors, to risk management, and yes, potentially to child protective services. You are effectively saying this parent is endangering this child. It's the only way to protect the child's organ in the doctor's license.
I have to push back strongly on this. Refusal places child at risk of significant harm as a weapon. It should be the absolute last resort, not something you just type because you're frustrated.
If the risk is real, the documentation must reflect it immediately. You don't wait until the organ is dead to write the note.
But you have to explore the why first. The guidelines are explicit about this. Why is the mother refusing? Is she scared of the cost? Does she think you're going to do surgery right there in the room? If you jump straight to the nuclear note and call security, you have failed as a communicator.
Does the why matter if the testicle is dying? Time is tissue.
It matters because if you address the why, you might get the exam done without calling CPS. If you say, I know the ultrasound is expensive, but if we don't do this, he could lose the testicle forever, that changes the conversation. If you explain, this will be a brief visual exam only, you can hold his hand, she might agree. I argue that labeling a parent as neglectful in the chart is premature, and it's damaging if you haven't done the heavy lifting of communication first.
But there is a difference between a low-risk refusal and a high-risk refusal. If a parent refuses a flu shot, fine, document it, move on. That's low risk. But refusing a workup for sepsis, refusing a workup for torsion, that is immediate danger. The emotional and legal weight of that injury on a jury is massive. If you spent 20 minutes exploring the why and the organ died, you have failed the standard of care. The clinician must protect the child over the parent's feeling.
I'm not saying let the organ die. I'm saying there's a step in the middle. The flowchart in the source material usually includes acceptable alternatives.
What alternative is there for torsion? It's ultrasound or surgery. There's nothing else.
Okay, maybe not for torsion, but what about the meningitis scare? Maybe the parents refuse the spinal tap, but they agree to admit the child for observation and antibiotics. That's a win. The documentation should show an effort to resolve the conflict, not just condemnation of the parent. Your note should read, mother declined spinal tap due to fear of pain, but agreed to admission, not just mother refused care. That nuance proves you were trying to be a doctor, not a prosecutor.
That brings us to the philosophy of the chart itself. You seem to view the chart as a narrative, a kind of story of the interaction.
I view it as a letter to the future. You're writing to the version of yourself or the jury that's going to read this in 5 years.
I view it as a cognitive forcing function. Good documentation is one of the strongest defenses because it forces you to think. The guidelines say a good note includes what was done and why, and importantly, what was considered but ruled out.
Like writing findings consistent with possible urethral irritation versus UTI?
Exactly. But more importantly, writing the negative. By forcing the doctor to write torsion cannot be excluded, it forces the doctor to actually think about torsion. It breaks anchoring bias, where you get stuck on the first symptom you see. If I force myself to type no meningeal signs, I have to actually check for them. This defensive writing actually makes the medicine better. It's not just covering your rear, it's clarifying your brain.
That is actually a compelling point. I agree that writing clarifies thinking. But I would argue the most protective part of that note is the element of shared decision-making.
How so?
Well, if you write discussed risks of radiation from CT scan versus the risk of missing appendicitis, mother chose observation. That proves the mother was a partner in the plan. It shows the jury and the medical board that you didn't just dictate orders from on high. You practiced medicine with the family. That protects you far more than just listing a bunch of negative findings.
It protects you if the outcome is bad, but the process was sound.
Precisely, and that's the goal, isn't it? We can't control every outcome. Kids get sick, bad things happen. But the best documentation proves that professionalism occurred. It bridges that gap between the cold legal record and the warm clinical reality. It shows you cared enough to explain.
But let's be honest about the limitations. You can have shared decision-making, you can have assent, you can have safety netting. But in the end, we are operating in a system where life expectancy creates this massive liability. Infants are developmentally vulnerable. They simply cannot tell us what is wrong. Therefore, the system, the protocols, the chaperones, the specific phrases like refusal places child at risk, that is what stands between a bad outcome and a tragedy. The clinician cannot be afraid to use the nuclear option of documentation when safety is on the line. You have to be willing to be the bad guy to save the patient.
And I conclude that while the system is the skeleton, the human factor is the flesh and blood. The strongest defense against a lawsuit isn't a perfect chart. It's a family that feels heard, respected, and educated. Neglect is actually quite rare. Misunderstanding is incredibly common. If we focus on safety netting and explaining the why, we solve the problem before it ever reaches a courtroom. You don't have to be the bad guy if you're good at being the guide.
I think we can find some synthesis in one core truth from the guidelines. Documentation supports communication.
Agreed. A well-documented encounter is evidence of thoughtful care. It proves you did the work, both the exam and the explanation.
It bridges the gap between the legal requirement and the human need.
And that is the balance every pediatrician has to find. It's not easy, but that's the job.
Thank you for joining us on The Debate. We encourage you to look at your own charts. Are you writing for the jury or for the patient? Maybe it needs to be both.
Until next time.